All right, everyone. So today we are going to talk about myeloma basics. And what I mean by this is essentially I'm going to help you try to understand when will you suspect that a patient has multiple myeloma. When you suspect, how do we evaluate? And after we evaluate, we put a particular diagnosis. What is the meaning of that diagnosis? And beyond that, when your patient, if somebody is diagnosed to have myeloma, when they go forward and they get treatment, you also should be oriented to how is myeloma treated. So that when your patients and relatives come back to you and say, the doctor is saying we have to do this, we have to do that, you would be oriented to the treatment of the disease. So every cancer, every cancer starts from one cell which becomes abnormal. There is one cell which picks up genomic errors, which are called mutations, and these errors cause the cell to multiply unnecessarily and spread. It also damages the cell so that the cell is not able to do its normal job. Now, this cell in multiple myeloma is the plasma cell. So, all of these cells that you can see here, right? These are plasma cells. How do we know these are plasma cells? They are relatively large, larger than RBCs. They have an eccentric nucleus. What that means is, see, nucleus is not in the center, it is at the edge. Then in the cytoplasm surrounding the nucleus, you see there is some clarity. There is some clarity. This is called perinuclear Hoff. Yeah. And the cytoplasm is purple blue. So this is how our pathology friends and how as a hematologist, when we see a cell like this in the blood or bone marrow, we say, hey, there are plasma cells which are increased. Normally, we have less than 5% plasma cells in the marrow, and we don't have any plasma cells floating around in the blood. Okay, normally, nothing in the blood and less than 5% in the marrow. Now, unfortunately, if a patient's plasma cell uh, DNA, if the patient's plasma cells DNA, which is inside the nucleus, if it picks up some mutations which make it malignant, right? Then the cells you can see multiply unnecessarily and they can't do their normal job. And this disease is called as myeloma. Now, because plasma cells live inside the marrow, they live in the factory where blood is made. So, plasma cells live inside the marrow, and because they're all around in the entire skeleton, as the cancer cells spread, okay, as the cancer cells spread, they will start damaging multiple parts of the bones because they are inside the bones in the bone marrow. And because there are multiple damages, and the damages look like holes in the bone, lytic lesion. And because there are multiple such things in the skeleton, we call it multiple myeloma. Okay? Multiple myeloma. Myeloma. Myle means marrow, oma means tumor. So, cancer of the plasma cell generally leads to multiple problems in multiple sites in the skeleton. Hence, it's called multiple myeloma. Now, what is the normal job of a plasma cell? What a plasma cell does is every cell, every plasma cell is a factory which makes immunoglobulin. It makes immunoglobulin. What that means is, suppose COVID virus goes inside me, okay? COVID virus goes inside me. The COVID virus will attack my body and my immune cells will go and try to understand it. My immune cells, T cells, B cells, etc., they will go and try to understand the virus. It will try to understand how do I identify this virus, which means what are the proteins on the virus surface which are different from my own protein. Okay. So any protein which is different from my protein and to which an immunoglobulin, an antibody can be made, it is called as antigens. So my immune cells will go and try to read, understand, feel the any infection, COVID, influenza, tuberculosis, right? Salmonella. What is your Vidal test? Essentially, anti-salmonella antibodies are there, correct? So it will try to identify an antigen on the infecting organism, which is different from me, and my immune cells will send this message. It will give this message to my plasma cells. My plasma cells will then say, okay, this is the antigen on the infecting cell. This is the antigen, and let me make an antibody against it. Let me make an antibody against it. So it will make these antibodies and secrete these antibodies into the blood. So that blood will carry these antibodies and kill that virus, bacteria, wherever it is in my body. So the job of a plasma cell is to create different kinds of antibodies for different infections, different kinds of antibodies, which means the antibody to influenza is different, measles is different, salmonella is different. My plasma cells can make multiple antibodies, polyclonal, okay? Polyclonal antibodies. My plasma cells can make multiple antibodies. What this means is if you take my blood today and you try to, do an electrophoresis of the immunoglobulin, you will see polyclonal immunoglobulin, which means my blood will have antibodies against tetanus, against tuberculosis, against smallpox, because I got smallpox vaccine. I was one of the last few, children who got smallpox vaccine, right? So it is polyclonal. I have multiple antibodies in my blood coming from normal healthy plasma cells which have secreted this. However, what happens is when cancer happens, I told you there is one plasma cell which will become abnormal. It will multiply and create its own clones which are similar to it. They look similar and they secrete the same antibody. They cannot secrete different antibodies. All right. So one bad plasma cell will form two, will form four, will form 16 and 64 and hundreds and thousands and lakhs of plasma cells. And all of these plasma cells, because they come from the same damaged cancerous plasma cell, all of them secrete the same antibody. They secrete the same antibody. Hence, they produce monoclonal, single clone immunoglobulin. Monoclonal. So, now this is a normal plasma cell. This is like my bone marrow. It is secreting different kinds of polyclonal antibodies. However, in multiple myeloma, if you take the patient's blood and send it to the biochemistry lab, and when the biochemistry lab does serum protein electrophoresis, or immunofixation electrophoresis of the proteins in the blood. And what are the proteins in the blood? Albumin, globulin, and other smaller proteins. Correct? Now, if my patient of myeloma has a lot of bad plasma cells, multiple myeloma cells, then they are all going to secrete lot of immunoglobulin, which is identical, monoclonal. And when we do electrophoresis, we are going to see that all of this immunoglobulin is the same. It's coming from the same abnormal plasma cell. It's monoclonal. It will make a band in the electrophoresis picture. And because it's a monoclonal immunoglobulin band, it is called M band. M band, monoclonal. So that, remember, this is the core concept. Okay. This is the core concept of multiple myeloma, and we will develop this as we go forward. So, sure, now you have a patient, you suspect there is multiple myeloma, and I'll tell you how you suspect. How are you going to diagnose? such an individual. What will typically happen is there are some problems that a patient can present with, which are called myeloma defining event, MDE, myeloma defining event. If any of these happens, the diagnosis is straightforward. Okay, now let us see what are these. So, if you have a patient and you do a marrow or the blood shows plasma cells, and I do a patient's marrow and I see plasma cells, or my pathologist sees plasma cells, and they tell me, Sachin, more than 60% plasma cells are seen. You see, less is normal is less than 5%. They say, Sachin, more than 60%. I said, okay, more than 60%, but maybe this patient's plasma cells are only reacting to an infection. Maybe the patient has TB, and plasma cells are multiplying as a protective system, right? Immune reaction. They say, no, 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 it is clonal. Clonal means they do immunohistochemistry on the bone marrow and they show, see, all of these plasma cells express the same kind of immunoglobulin. By immunohistochemistry, you can do that, or by flow cytometry. They show all the plasma cells have the same light chain. So these are clonal plasma cells. These are not normal, healthy, polyclonal plasma cells, which have multiplied as a reaction to infection or inflammation. Okay. So once you see clonal plasma cell, clonal, more than 60% cancer, nothing but multiple myeloma. Then these plasma cells, I told you they secrete immunoglobulin, correct? And this is how a immunoglobulin chain looks like. It has one and two heavy chains, and one and two light chains. So normally, if you take my blood and you get immunoglobulin specific to COVID or hepatitis B, because I have taken hepatitis B vaccine. So if you measure, you will get anti-HBs, right? Immunoglobulin. And you look at it by, say, X-ray crystallography or some other advanced techniques, then you will see every immunoglobulin molecule has two heavy chains and two light chains. This is a normal. But myeloma, the cancer cell, is a damaged cell. It is a damaged cell. Yes, it may make monoclonal immunoglobulin, but it will also make some extra free light chains. These light chains are free, they are extra. Unnecessarily, it is making them because it is damaged. And these light chains are not sticking to heavy chain. And there is a blood test for it, which we call as serum free light chain ratio. So suppose, these light chains, they can be kappa light chain or lambda light chain. There are two kinds of light chains, right? Some immunoglobulin will have kappa light chain, some immunoglobulin will have lambda light chain. Okay, some will have kappa, some will have lambda. Now suppose the cancer cell is only secreting kappa, because I told you it will only secrete the same monoclonal protein. It may be just the light chain protein. If that affected, suppose a patient has kappa myeloma, then it is only secreting kappa, and the kappa is 100 times more than lambda. 100 times more than lambda. Normally, they are almost equal. Kappa lambda ratio is equal. If it is 100 times more than lambda, or lambda is 100 times more than kappa, then you say, no, 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 this can't be normal. If there is 100 times more, means there are some cells which are multiplying and they're unnecessarily secreting this monoclonal. They will, some of them will secrete the entire immunoglobulin, or some of them will only secrete the light chain, right? So if you are free, serum free light chain ratio, the affected chain is 100 times more than unaffected chain, myeloma. There can be nothing else. Similarly, you have lytic lesions in the bone, right? Lytic lesions in the bone. And you see, sometimes patients will come with this X-ray, where there are these holes in the bone, in this skull X-ray. And if there are multiple holes and they are more than 5 millimeter, okay, and sometimes we can't see this on X-ray, and we have to do MRI. And the MRI, I don't know if you can see this, but there are some holes in these vertebral bones as well. And when this happens, and plus you are getting these clonal plasma cells, free light chains more than 100x, you say, hey, this is a myeloma defining event. This patient has nothing but myeloma because there are too many cells. They are secreting monoclonal protein, and it is multiple skeletal lesions, right? Then there is something else that we look into to confirm that a patient has myeloma. What do we look into? The end organ damage that cancer cells are causing. See, these cancer cells will spread throughout the body and they can damage. And in myeloma, what happens is the plasma cell may be sitting only in the marrow, but it is secreting this abnormal immunoglobulin, abnormal light chain, monoclonal light chain. This can go in the blood and damage organs. Okay. And it damages the organs and it leads to certain features which we call crab, crab, right? As in the shell, animal with the shell, crab. Now, what is this crab? C stands for calcium. So the calcium will be high, hypercalcemia. So if the calcium increases more than 1 milligram from the upper limit of normal in your lab, or on the whole, if the calcium is more than 11 milligram per deciliter, that's very high calcium, then we say, okay, this person has hypercalcemia. So in the crab, the C is present. R stands for renal insufficiency. What happens in myeloma is the immunoglobulin will go through the blood into the kidney and it will go through the glomerulus into the renal tubule and block the renal tubule. Block the renal tubule. The light chain will go through the glomerulus, filter through the glomerulus and enter the renal tubule and block it and lead to nephropathy. Generally presents as CKD, chronic kidney disease, slowly evolving kidney disease, right? So the second thing in crab is renal insufficiency, means creatinine going up or creatinine clearance coming below 40. The next A is anemia, which means hemoglobin is low because the bone marrow is packed by bad cancer cells. Remember, if the factory is packed by bad cells, good cells cannot work. Hemoglobin cannot be made. So the hemoglobin will drop more than 2 gram below the lower limit of normal, or it will drop below 10. And last, B in the crab. So calcium, renal insufficiency, anemia, and bone lesion. I just showed you the skeletal lesions. If there are one or more osteolytic lesions. So what I've told you until now is when we want to diagnose or we want to rule out multiple myeloma, we use these two parameters, myeloma defining event and crab features. Now, let me tell you how we combine these two. Because you will ask me, Sachin, calcium can be high because of different reasons. Creatinine may be high because of something else. It may be diabetic nephropathy, right? It may be a glomerulopathy. Anemia can be there because of so many reasons. Bone lesions, lytic lesion can be because of metastatic breast cancer. So, how do we use CRAB to diagnose myeloma? How do we combine these? That's what we will come to now. Now, multiple myeloma is a very interesting cancer. The reason it is very interesting is, see, plasma cells, no, they multiply very slowly. Okay, plasma cells do not multiply rapidly. In acute leukemia, the WBC, cancerous WBCs, they multiply very rapidly. So patient presents within 3 to 4 months. But in multiple myeloma, these are long living cells. They multiply very slowly. And initially, the patient may have some increased plasma cells, which are monoclonal. Okay. And they are secreting some monoclonal immunoglobulin, but it has not advanced to a stage where there is end organ damage, which means this patient has the plasma cell. Yes, it is cancerous. They are multiplying a little bit, but they have not gone to 60%. Yes, they're secreting some monoclonal protein, immunoglobulin, but that is not so much that it will increase calcium, damage the kidneys, or anemia or lytic lesions. This patient, when they come to you, they may present with neuropathy. neuropathy. They may present with some mild anemia. Okay. They may, but still not very severe anemia. Okay. Not less than 10. They may present with globulin being high. So you have done liver function test for whatever reason, and the LFT says that albumin is okay, but globulin is slightly high. The AG ratio is reverse. Globulins are increasing, but still it is not so high. Globulins are not so high. They are monoclonal. They are not so high that they are damaging the body. So whenever you have a liver function test or a neuropathy patient, neurologist will do serum protein electrophoresis. The protein electrophoresis will show an M band. So yes, there is monoclonal protein. It will be a small M band. And then M band means monoclonal gammopathy. Gammopathy means globulins are high. These are gamma globulins, no? Globulins are high. So monoclonal gammopathy. But they are also such small quantity that you don't know whether you know what to do. So it's called monoclonal gammopathy of undetermined significance, MGUS. Monoclonal gammopathy of undetermined significance. This is the first stage of multiple myeloma. This is a stage where, yes, there is a few cells, but not that much. And what do you do? Nothing. Wait and watch. It's too small. And if we try to treat it, the side effects will be more and benefits will be very less because MGUS patients can progress to myeloma. So if you have 100 MGUS patients and you follow them for 10, 15 years, small number of them will progress to myeloma. How small? 1% per year. That means today I have 100 patients with MGUS. Next year, 99 will remain in MGUS. One would have progressed to multiple myeloma. 2027, 98 will remain in MGUS. One more will turn into multiple myeloma. So only 1% per year. So MGUS is very early stage. Don't treat, just follow them. Okay. Why? Because the next step is as the cancer cells multiply, they will actually turn into a myeloma, which means the number of plasma cells will increase. They are secreting more immunoglobulin, but still they are not damaging the body. No end organ damage. No end organ damage, which means, yes, there is a terrorist sitting, but as of now, he is not doing anything. Should you go and kill him? Right? There's no end organ damage, no crab, no myeloma defining event. Okay. So this is called as smoldering myeloma. It's a smoldering, like a smoldering coal. It looks red, but there is proper fire is not there. And a few years later, smoldering myeloma will turn into active multiple myeloma, where now the plasma cells have really increased and they have started causing CRAB or MDE. Okay. So these are the stages. And because myeloma is a slowly growing disease, we have been able to study this, and research has shown how some patients with MGUS, they develop more mutations, progresses to smoldering, more mutations, progresses to active myeloma. Remember, in medicine, we are not treating the number. Even if you have some increased monoclonal plasma cells, even if you have some M band, you have to be sure that that is not MGUS. Okay. If it is not fitting in the criteria of active myeloma, we don't treat, because sometimes treatment may be worse than the disease, right? So let us see how do we actually differentiate these three. It's actually not difficult. MGUS, monoclonal gammopathy, means this monoclonal gamma globulin is there in the blood, but it's of undetermined significance. Like I said, there are few plasma cells, or there is a small monoclonal protein in electrophoresis. No crab, no end organ damage, which means you have plasma cells in the marrow less than 10%. The M band, that serum monoclonal protein, is less than 3 grams per deciliter. There is no end organ damage, which I told you. Okay. So less than 10% plasma cells, less than 3 gram per deciliter. So 30 gram per liter means 3 gram per deciliter. So less than 3 gram per deciliter of M band, no end organ damage. Okay. This is MGUS. There are some subtypes of this. I'm not going to get into this, right? But MGUS can move on to smoldering multiple myeloma. Smoldering means, yes, now the number of plasma cells are increasing more than 10%, but not more than 60%, right? Remember, MDE, myeloma defining event, was more than 60% plasma. So now the plasma cells are more than 10, but less than 60. The M band is more than 3 grams now. Okay. Even the urine may have an M band. Urine electrophoresis may show monoclonal protein, but still no end organ damage. No hypercalcemia, renal failure, anemia, or bony lesions. Okay. And eventually, when it moves on to multiple myeloma, means that either plasma cells, monoclonal plasma cells, are more than 60%. Okay. And there is now end organ damage. So I told you calcium, renal, anemia, or MDE. Then we say now this is active multiple myeloma, we have to treat. What is this solitary plasmacytoma? I told you multiple myeloma has multiple lesions. Sometimes in patients, what happens is the plasma cells don't spread too much. They just grow into one area and create a lump. They create a tumor. OMA, plasma cytoma, means plasma cells are creating a tumor. So rather than multiple, only in one place they are growing. Solitary plasmacytoma means there is a single lesion. Okay. When you biopsy, yes, it is full of plasma cells. They are clonal, right? And it's not seen anywhere else. So suppose somebody has a plasmacytoma of the humerus. I biopsy it. I will get clonal plasma cell. But when I do a marrow from the iliac bone, from the iliac crest, there are no increased plasma cells. Means the plasma cells are only here. Okay. So the bone marrow is normal. There are no clonal plasma cells in other parts of the body. Even with a sensitive MRI, I am not seeing any lytic lesions except for this one lesion, and there is no end organ. This is called as solitary plasmacytoma. Okay, just a minute. Right? Solitary plasmacytoma is only in one place. You don't have to do chemotherapy, which will go through the whole body. You don't, I mean, what is chemotherapy? Chemotherapy is any medicine that kills cancer cell. It may be a tablet, it may be an injection, but we give it so that it goes in the stomach, or we give it as an injection so that it floats in the blood and kills the cancer cell wherever they are. But solitary plasma cell is only in one place. So why give chemo? We can just give radiation. That is why it's important to figure out, is it multiple myeloma? Is it solitary plasmacytoma? If it's multiple myeloma, I have to do chemotherapy because it's multiple. And then I have to do a bone marrow transplant. Solitary plasmacytoma, just irradiate, and for 2 to 3 years, the patient may not require any treatment. We have one patient right now who came from Canada, Indian person, software engineer from Bangalore, living in Toronto for several years with his family. Somewhere he had back pain, and that was 2 3 years ago. He had back pain, and he went to his GP. And in Canada and all that, sometimes it takes time to do the test. Initially, he gave him paracetamol, did not resolve. Then gave an appointment for X-ray after 2 weeks or 3 weeks. Then X-ray was done. Then they said, yeah, maybe there is some compression fracture of the vertebra. So they said, you will do a CT scan of the spine. So CT scan showed, yes, there is a compression fracture. And plus, not only is the vertebra fractured, there is some soft tissue around it. Okay. So they said, we will do a biopsy, a CT guided biopsy of that tumor. When they biopsied in histopathology, it showed plasma cells, monoclonal plasma cells. Polyclonal plasma cells, same place, vertebra with a vertebral fracture, could be TB. But monoclonal means myeloma. So they got very scared, and they were asked to see an oncologist in Toronto, and they didn't want to wait. They realized it takes so much time, and they were told, hey, you may be having a cancer, blood cancer called multiple myeloma. So from somewhere they got my number and they met us. So we did the whole workup. We did the blood test, bone marrow, PET CT of the whole body to see if there are any other lesions. PET CT, we did not see any lytic lesions except this one in the vertebra. The blood showed some M-band, but small M-band. Bone marrow did not show any plasma cells. So then we came to the diagnosis, hey, this is a single area where cancerous plasma cells are growing. And that soft tissue tumor is actually a swelling of the plasma cells, cancerous plasma cells, which are multiplying. All that we did is we gave him radiation, and then we sent him to our orthopedic colleagues. They stabilized the vertebra so that it does not collapse and cause neurodeficit by impinging on the spine or spinal nerves. So we stabilized the vertebra by surgery, plate and screws. And we just gave local radiation, and we said, hey, you don't need any chemo, you don't need any bone marrow transplant. This is not multiple myeloma, this is solitary plasmacytoma. That's how it's important to know. On the other hand, I had another patient several years ago. He was in his 50s. He was the head of department of pediatrics in one hospital in Nigeria. A wonderful guy. And he was, he went to work, he went to his department, his office, and in his office there was a cupboard, and on the cupboard there was a file. So he reached out to just lift that box file with some papers. What will be the weight of that? 100 grams. And that broke his humerus. Just that weight, lifting the box file with papers broke the humerus. Now, this humerus had plasma cells, lytic lesion growing, and it had become like butter. So even when he just lifted a box, that broke. Then he went to a local doctor. They thought they will do open reduction internal fixation. Thankfully, when they were operating, they took a biopsy. So remember, when to tell your orthopedic friend, hey, if you're seeing some fragility fracture, right? Means fracture which happens because the bone is weak and the impact is not so high to cause a fracture. That time, please take a biopsy. Biopsy showed myeloma, sorry, plasma cells were there. And then when the bone marrow was done from the iliac bone, even that showed plasma cells. That means the plasma cells in the lytic lesion, plasma cells in the bone marrow. That tells you there are multiple areas of monoclonal plasmacytosis, multiple myeloma. That's how we differentiate. All right. So now a patient is sent to us, or you have suspected because there's some anemia, hypercalcemia, fragility fracture, right? CRAB or renal problem. You're not able to explain the renal problem. The kidney size is shrunken in chronic kidney disease, but the kidney size is good. Maybe diabetic nephropathy, maybe myeloma. So in myeloma, I told you the renal dysfunction will happen, but that is because there is deposit of light chain of the faulty immunoglobulin. So size remains good. So normal size kidneys with increasing creat, CKD, must be diabetes or myeloma. So now or you have done a liver function test where the globulin level is high, and now you suspect, hey, this may be myeloma. How do I evaluate? You'll take a history. You'll say, hey, have you ever had fractures? Low hemoglobin, blood transfusion, kidney failure, or in your previous blood test, was the calcium ever high? That's a history. Many times, we miss calcium. And fortunately, unfortunately, now whenever you go to any lab to do a health checkup or whatever, they do 100 tests. Along with CBC, LFT, they'll do testosterone level, FSH level, vitamin D, calcium, phosphorus. So you ask for old reports. See if the calcium has been high in the past. See if there was hemoglobin slowly dropping over months and years. Okay, see if the globulin fraction was slowly increasing over years, because from MGUS to active myeloma may take 10 years. Examine for anemia, lymph nodes, liver, spleen, usual examination in hematology. Key thing here is there is one type of myeloma called IgM. It's actually called Waldenstrom's macroglobulinemia. Waldenstrom's. In Waldenstrom's, you have monoclonal protein which is of IgM type. IgM. The cancer cell is secreting faulty IgM. And in Waldenstrom's, we may get enlarged lymph nodes and liver and spleen enlargement. We don't see this in other types of myeloma. Okay. So anyway, standard hematology examination, we do the laboratory work. The blood work shows complete blood count. Sure, you're looking for anemia, but we have to do the peripheral smear review to see if there are floating plasma cells. Because if the plasma cells are floating in the blood, then that's very bad myeloma. That is called as plasma cell leukemia. And plasma cell leukemia is an aggressive type of myeloma. And, of course, with modern treatment, we are able to control the disease, but cure is very rare. So it's very important to look for plasma cells in the blood. If that's, they should not be there. If they are there, this is plasma cell leukemia, which is very aggressive myeloma. You will look at the liver, especially the globulin level. You look at calcium, creat, and then you will see whether there is any monoclonal protein in the blood. For this, you will do serum electrophoresis of the proteins with immunofixation. That will tell you exactly, yes, there is an M band. What kind of M band is it? Is it IgG, IgA, IgM? Immunofixation will tell you the type of M band. You will do free light chain assay. I told you, it will tell you, is it IgG kappa, okay, or IgG lambda, or IgA kappa, IgA lambda. These are the specific diagnoses, and the prognosis changes a little bit, right? We also measure the serum immunoglobulin level. What is the IgG level in the blood? IgA, IgM. So, for example, one patient's monoclonal cancer cells may be secreting IgA kappa. Somebody else's may be secreting IgM kappa. Why do we need to know? Because after treatment, I'm going to keep on measuring this every 2 months. You see this M band in the blood. It's a tumor marker. It's a tumor marker. So every 2 months when I check the blood, if the IgG kappa, if the M band, it was 5 grams, now it has become 3.4 gram. So just by measuring the protein in the blood, I can guess whether the plasma cells in the body are dying or not. If the monoclonal protein, the free light chain, the affected free light chain is coming down, means the treatment is working. So monoclonal protein is tested in blood, and you can also check in urine if blood is not giving you a diagnosis to see how is my chemotherapy controlling the cancer. Okay. So suppose at diagnosis, a patient has IgG kappa myeloma. Okay. And M band is, like I said, 5 grams. And serum free light chain assay shows that the kappa is 800 or 1000. I start chemotherapy. 2 months later, I repeat M band. M band has come from 5 grams to 4 grams. Not a great response. But if it is less than 50%, 5 grams has become 2 grams, less than 2.5, less than 50%, partial response. If 90% reduction means 5 grams, less than 500 milligram is left. That means 90% reduction. Very good partial response. So, partial response, very good partial response, complete response means M band becomes 0. Right? So, we use monoclonal protein for diagnosis and we use it for follow-up. You can't repeat a bone marrow every time, right? It's a painful procedure. So this is where we can just look at this as a tumor marker in the blood, and serial assays can be done. At the same time, when a patient is relapsing, the M band will increase. Serum free light chain will increase, right? So this is how we follow up. At diagnosis, what typically happens? Not everybody has CRAB. So only 73% of patients have anemia. About 80% have lytic lesions, which means 20-25% will not have anemia, will not have lytic lesions. And only 19% have high creatinine. Okay. Because in today's world, we are able to diagnose patients early. Many times we are diagnosing patients in the EMGA stage or smoldering myeloma stage. And we have to decide, is there really CRAB? Is there MDE, myeloma defining event? Shall I start treatment or shall I only wait and watch? Why give chemotherapy which is going to cause side effects and expensive and stress, right? So we have to understand that not everybody will fulfill all the criteria. So we have to be very careful in diagnosis. Yes, we do the marrow, we do an aspirate and biopsy, and we measure the percentage of plasma cells. I told you less than 10%, 10 to 60%, more than 60%, right? So MGUS, smoldering, and active myeloma. Along with that, we also want to do the genomic testing of the cancer cells. So we send for cytogenetics, FISH, and we also do immunophenotyping, flow cytometry nowadays. We have to look at something called as MRD, minimal residual disease. So the cytogenetics, the kind of genomic abnormalities in the myeloma cell will help us understand the prognostication. Okay, what is the chance that I can control this patient's myeloma, and how long can I control? That depends on how bad the genomics of the cancer cell is. So now, finally, we would also do imaging. I told you, you can, in absolutely poor patients, we just do X-ray, skeletal survey of the skull, chest, cervical, thoracic, and lumbar vertebra, pelvis with both hips and humerus. Okay, so that's how we do the epilateral X-rays, the cheapest. But if they have some money, it's good to do a whole body PET-CT or MRI, because those are the most sensitive in finding out lytic lesions. Sometimes lytic lesions can't be seen on X-ray, right? So we do all of these things and we label. Then the patient will ask me, doctor, how bad is it? Okay, I have myeloma. How bad is it? And then we come to prognostication. So for prognostication of myeloma, we use a system called as the RISS, the Revised International Staging System, RISS. And this is actually very simple. There is RISS stage 1, 2, 3. Okay, 1, 2, 3. RISS stage 1 is dependent on the beta 2 microglobulin in the blood, depending on the albumin, depending on the genomic abnormalities, and we combine all of that information and we say, hey, you are stage 1, stage 2, stage 3. Why should we do that? Because you see, this is progression free survival. That means 0 is the time when I have diagnosed 100 patients. Okay, blue is RISS stage 1. You see, blue is RISS stage 1. Median PFS is 66 months. That means 66 months later, 50% of patients have progressed. So if I have 100 patients, half of them will not progress for 66 months. That means for 5 years, if you give proper treatment with chemotherapy, bone marrow transplant, for 5 years, this disease will not progress. You can go back and live your life. Okay. However, if you look at RISS 2, stage 2, you see 50% is 42 months. That means in stage 2, within 42 months, half of them would be progressing. And in stage 3, median progression free survival is only 29 months. That means if the RISS is stage 3, then 29 means just over 2 years the cancer will come back in half of the patients, median progression free survival. Same thing for overall survival. If you are stage 1, you see, even if you follow for 72 months, that means 6 years, still only 20% have relapsed. They are all 20% are dead, 80% are still alive after 6 years. And remember, myeloma is a disease of the fifth and sixth decade. So for that person, 5, 6, 7 years of life, cancer not coming back is great. Okay. And if you look at RISS 3, then half of the patients are dead in 43 months. Not good. Not good. So prognostication is very important to tell the patient, hey man, don't worry. If we have to give treatment, and this is the average time period where the cancer will probably not come back, right? This is important because myeloma is not a curable disease. Okay? Myeloma is a chronic low grade cancer. We give treatment, chemotherapy, bone marrow transplant to postpone relapse, to prolong disease control. It can only be cured by allogenic stem cell transplant, which we don't do in most of the patients for myeloma because the toxicity is too much for this disease. See, allogenic bone marrow transplant is a complex transplant. The benefit has to justify the risk, and that is not justified in myeloma. So we can't do allogenic for majority of the patients. So majority can't be cured. It will only be controlled. So it will be controlled for a few years. It will come back, and you have to give the second line treatment. Fortunately, today in the last 10 years, we have five, six, seven, eight different lines of treatment, from chemotherapy to immunotherapy to white cell therapy to CAR T cell therapy. So, as the cancer comes back, there are multiple different treatments which can be given, provided, of course, we have access and provided, of course, the patient is able to afford, unfortunately, in our country. With this, we try to postpone the relapse as much as is possible. But how? What do we actually do? How do we actually treat myeloma? Like I told you, you see in the last 10, 12 years, there are so many new therapies. Just look at this diagram. So many new therapies have been discovered, right? And how we select them? NDMM means newly diagnosed multiple myeloma. We use a combination of three or four chemo medicines. If required for a lytic lesion, we give radiation. And when the disease comes under good control, we do a autologous bone marrow transplant. Autologous stem cell transplant means taking the patient's own stem cell, which is safer and effective. With this, on an average, we can control the disease for 3 to 4 years. But you have seen in our ISS stage 3, it is 29 months. In stage 1, it is 60 months. So, depending on the prognostication, but average, we can control the disease for 3 to 4 years. Then it comes back. When it comes back, it is called as relapsed multiple myeloma. Okay. And hence, in the beginning itself, when we diagnose, we have to decide, is the patient young? Young means if the patient is less than 70 years old or even 75 years old but healthy, and if they have the funds, and if the patient is willing, we give chemo, we do autologous stem cell transplant. If we can't do autologous transplant because they can't afford, or general condition is bad, or patient is 77 years old, right? In that case, there is no transplant. So after chemo, we just give maintenance. Initially, we give three, four medicines together as a protocol. And later on, maintenance, we only give one or two medicines for the next 2, 3 years to keep the disease under control. Maintenance is also done after transplant, by the way. Okay, so if possible, we should do transplant and then maintenance, and the cancer will come back practically in everyone. I only know two patients, okay, in the last 19, 20 years of hematology practice, after managing several hundred myeloma patients, I only know two patients who after 11, 12 years have not had a relapse. Okay, otherwise everybody will relapse in an average 3 to 4 years. Once they relapse, we have to see, all right, previous time we used this medicine, let's change the regimen. Let's use a different medicine which is not used, or let's try a novel newer medicine like daratumumab, etc., etc. If possible, we even do a second bone marrow transplant for myeloma, right? So that's how relapsed myeloma is treated. So that is it for today. How we suspect, how we figure out, yes, there may be a plasma cell neoplasm cancer, but is it very early in EMGA stage, or smoldering, or is it active? Is it solitary plasmacytoma or multiple? What type is it? Is it IgG, A, M, kappa, lambda? Is it is the genomics bad? Is it ISS stage or ISS stage 1, 2, 3? Can the patient tolerate chemo? Can the patient tolerate transplant? Post transplant, give maintenance and then follow up. Thank you so much. I'll be happy to take questions if any.
Thank you, Sachin sir, for that simplified session on multiple myeloma. Over to the audience for any queries. Please unmute yourself and try to ask your question.
Sir, I have a question.
Sure.
So clinically, 60 years old,
Mhm,
diabetic, hypertensive,
mhm,
and very well controlled. But generally, they'll start complaining of neuropathy symptoms as the
mhm,
duration
mhm.
of diabetes and hypertension progresses. So
Mhm.
in that condition, presenting with neuropathy symptoms, and as you said, this MGUT. So how do
MGUS.
we clinically, youngest, how do we differentiate during that time, sir?
So, what we do is you do a liver function test, do a creatinine, calcium, CBC, send a protein electrophoresis or immunofixation electrophoresis, and a free light chain assay. If your protein immunofixation electrophoresis and free light chain assay are negative, then it's not MGUS.
Okay.
Okay. Sometimes what
Okay.
happens is you will have a small free light chain or small M band, and if by chance your neurologist does a nerve biopsy, the nerve biopsy may show amyloid deposition. Amyloid is also kind of abnormal protein which can be deposited in the tissue in myeloma. I did not touch upon that. But if generally your M band is not there in immunofixation electrophoresis, and if your free light chain assay is not there, it's unlikely to be MGUS related neuropathy. Okay. Yes, if there is even small emband, then you have to do a marrow, whole body MRI or PET CT to rule out myeloma. Because in that case, if the neuropathy is because of myeloma, treatment of myeloma may help the nerves recover. Similarly, if the kidney failure is because of myeloma, rapid diagnosis, quick treatment can help the kidneys recover. So your question is very pertinent, but this is the screening test, the blood test, protein immunofixation electrophoresis and serum free light chain assay. Okay.
Thank you, sir.
Sir, good afternoon, sir. Sir, I
Fine.
just want to know a lot of people are now going for DEXA scan during pre-health checkup. Can it help in the preemptive diagnosis of myeloma? Low DEXA scans, low bone density. Shall we then, in that case, investigate them also further?
DEXA scan cannot help. See, DEXA scan only tells you that the bones are porotic, right? If by chance it shows a lytic lesion, it may, but generally DEXA scan does not help in looking at skeletal lesions.
All right, sir.
Good evening, sir. I just wanted to ask you a question. I've just shared a report of a patient on our group. Just wanted to know
Your,
how to interpret the report of protein electrophoresis, which I had shared on
your
our
voice
group
is
just now, sir.
breaking. I didn't understand. I'm sorry. Your voice is breaking. Could you please repeat from the beginning?
Sir, I have shared the report of a patient. Am I audible now, sir? Hello. Am I audible now, sir? Hello.
Hello, Sachin sir.
Yeah, sorry, there was a network drop from my side. Yeah,
Okay, sir.
yeah, sorry.
Sir,
Yeah.
I have shared a report of protein electrophoresis of a patient in the group. If you could just tell us that how do we interpret the report of this protein electrophoresis?
So this report you have sent in our WhatsApp group.
Ji sir, yes sir.
Okay, I will look at that and I'll reply. While I'm opening this up, I'll just respond to what Dr. Sujata has asked. Is solitary plasmacytoma always in the spine? Not at all. Like I said, it can be in the humerus, it can be femur, radius, ulna, skull, wherever there are plasma cells which are abnormal, they can grow. Rarely we even get infiltration of the lung or we get a pleural plasmacytoma, exceptionally rare, but it can be wherever there is a marrow. Now, Dr. Rajat, in terms of your patient's protein electrophoresis, the total protein is 5.2, albumin is 2.4, and gamma globulin is 0.73. There is an M spike, and that M spike is huge, 7 grams. This is a myeloma. No, sorry, it's zero point
It
0.1
is
gram.
for
0.1 gram,
0.1.
sorry.
Yes, sir.
0.1 gram. So this is MGUS. Now this looks like MGUS, okay? Because the M band is less than 3 grams, like I told you, it's only 0.1. So now you have to do free light chain assay, you have to do bone marrow, and you have to do whole body PET CT or whole body MRI. This could
Okay,
very
sir.
well be MGUS. Thanks for sharing
Yes.
this.
Because in the report they have mentioned that suspicious non-discrete protein band and gamma globulin region. So that's what
Yes.
I wanted to like in these type of reports, sir. How do we interpret the report? Like any spike
You,
they are in?
I mean, the interpretation is, well, there's probably a small M spike. That's it. That's the
Okay,
interpretation of that report. Now, this small M spike could be MGUS, it could even be myeloma, okay? There is one rare variant of myeloma that I didn't talk of, which is called as non-secretory myeloma. Non-secretory. Non-secretory myeloma means that myeloma cell is so messed up that it can't even secrete immunoglobulin or light chain. So this might be a non-secretory myeloma, which is not secreting or secreting very little monoclonal protein. So you have to evaluate. You have to do serum free light chain assay, bone marrow aspirate biopsy, and whole body PET CT or whole body MRI. Without that,
okay,
you
sir.
can't say that this is MGUS or something else.
Okay, sir. Thank you, sir. Thank you.
You're welcome. Any other question? So Dr. Revati has asked, is there any way we can prolong the MGUS stage? Wonderful question and a very hot area of debate in myeloma experts. Like I said, the number of people who will progress is only 1% per year. There is active research going on. There are randomized control trial. What if we give very low dose chemotherapy drugs, which do not cause side effects? Will that help? As far as the last paper, which was published last year that I'm aware of, that did not help. The treatment arm and the placebo group, that is a control group, had similar outcomes. In such low grade diseases which do not actually progress, uh, uh, you know, it's better not to treat. Okay. Dr. Samina is asking, how will normal serum protein electrophoresis report look? It will look exactly like this, what Dr. Rajat sent. Okay. So when you do electrophoresis of the, can you guys see this, what I'm sharing?
No, sir, we can't see.
All right. Sorry. Wait. Okay. Can you see the screen now? So
Yes,
this is
sir.
how normal electrophoresis, protein electrophoresis report looks, which
Sir,
means
can you please enlarge it, sir?
I will. Okay, is this better?
Ah,
Yes, sir.
perfect.
Yeah. So you send a serum tube, that's a clotted red top tube, to the biochemistry lab. They will centrifuge it, remove the RBCs, WBCs, platelets, and what is left is serum. This serum, you put it on an agar gel and you put current on both the sides. Now that current will drag the proteins. Okay. So if you have negative terminal here and positive terminal here, then the negative charged proteins will get sucked towards the positive electrode, and the positive charged proteins in that plasma sample will get sucked towards the negative electrode. So this is how the proteins are separated out after electrophoresis. This peak, then it will measure the amount that, all right, the protein is separating into first band, second band, third band, fourth, fifth, sixth, and seven bands in this patient. Okay. And what are these bands? Some is albumin, Another band is alpha 1 globulin, third band is alpha 2 globulin, beta 1 globulin, beta 2 globulin, and gamma globulin. That is our immunoglobulin, right? So there are these 5, 6 bands, and it will also measure how much protein is there, what is the quantity. So you can see because albumin is 2.1 grams per deciliter. Okay, everything else is smaller than albumin. That means in this patient's blood, maximum protein is albumin. The first spike is albumin, highest spike. Okay. The next spike is alpha 1 globulin 0.52. Third is alpha 2 globulin, that is 0.87. See, it's slightly bigger than alpha 1, 0.5 to 0.87. Then you have a tiny beta 1 globulin 0.31, and this is the gamma globulin. Within this entire gamma globulin, there is one band which looks like monoclonal, very tiny, 0.1 gram per deciliter, very tiny. Okay, so they are not sure what it is, but you see this image on top, this is the electrophoresis. So the serum was dropped somewhere, there is a positive electrode, negative electrode, and that will separate out the proteins with different electric charge, and then depending on how dark the band is, it will measure the quantity of the protein. This is how a normal protein electrophoresis report looks. Thank you so much for sharing this, Dr. Rishabh.
Thank you, sir.
So for doing all these special tests, any particular lab is good, or
So,
anything you refer,
yeah,
sir?
so these tests are pretty well standardized now, and because they are biochemical tests, they are done on machines, right? You don't need a good biochemist. It's a machine. You put the blood in it, it will run the reagent. So most of our national labs, so Lalpath or Onquest or Thyrocare, I mean, all of these tests are pretty standardized. You can send to any standard national lab, you'll get a reliable report. Yeah, it's the bone marrow examination which is dependent on the hematopathologist, or when we report hematologist. But biochemical blood test you can send to any BL accredited lab. Generally, they will give a good report.
Thank you, sir.
You're welcome. Anything else? Any other question? Let me look at the chat box.
So what would be the cost? Because patient come to us, we have to discuss
Yeah,
sometimes roughly, depends on hematologist. But as primary care providers, they will come and ask what is the tentative cost. So
yeah. So, see, if you're suspecting myeloma in anyone, they have neuropathy, nephropathy, anemia, skeletal lesions, there is a myeloma panel available. Okay. So they will take the blood sample and they'll run everything. They'll do immunofixation, electrophoresis, free light chain assay, beta 2 microglobulin, which is generally done in most of the labs, I think, for 5,000 to 6,000 rupees. So it's better just do the myeloma panel. So, Dr. Pradeep Gund has asked, in some patients, electrophoresis is normal, but light chains are elevated. Like I told you, some myeloma cells cannot secrete the whole immunoglobulin. They'll only secrete light chain. That is called as light chain myeloma. And it depends on how high is it. If it is more than 100 times, if say kappa is say 100 or 200 and lambda is only 1, so if it's more than 100x of the other chain, then it's myeloma. It's a myeloma defining event. Sometimes one, light chain may be increased, but not 100x. Again, it is exactly like this electrophoresis report. There may be an M band, but very tiny. At that point, you have to do a full workup. You have to do marrow, PET CT, etc. So, Dr. Vijayashree is saying beta 2 microglobulin means light chain. No, beta 2 microglobulin is a different protein. Light chains are part of the immunoglobulin chain. Biologically, there is some similarity, but the tests are different. The proteins are different. Then Dr. Shahina is asking, if a patient is diagnosed with MGUS, how frequently should we monitor for progression of disease? Once a year. Once you've confirmed MGUS, we check them once a year. And we tell them in between if there is any problem, fractures, renal, calcium, come to us quickly. Otherwise, once a year evaluation is enough. So once we diagnose, no, the first year we see them more frequently, once in 3 months. Then we make it once in 6 months. Then we make it once a year if there is no progression. But that's a very good question. One more question. Can bone alkaline phosphatase useful for lytic lesion? Not really. Bone alkaline phosphatase will only tell us that there is increased bone turnover. What is the cause, right? Cause can only be found by these proper biopsies and electrophoresis. But again, good question, Dr. Pradeep.
Sir, one doubt, sir. Sir, beta 2 microglobulin levels also we need to measure along with plasma light chain levels.
It's used for prognostication. I told you in the RISS, we need the beta 2 microglobulin. So it's not used for diagnosis, it's used for prognosis.
Okay, sir, level varies with the treatment, sir. It will come
It
down with
does.
the treatment.
It does. Because it comes down with treatment, it may again go up with the relapse.
Okay.
But that is not the tumor marker. The tumor marker is M-band and free light chain assay. See, beta 2 microglobulin is a very curious protein. It increases in myeloma because kidney is affected. See, normally in my blood, beta 2 microglobulin goes out in the urine. But if my kidneys are damaged by whatever, the beta 2 microglobulin will increase. That's all. So, beta 2
Okay.
microglobulin in myeloma is a marker of end organ damage. It is not a marker of the disease per se.
Okay. Thank you, sir.
You're welcome. I'm really liking the discussions that we are having. I'm getting a feeling, I'm not sure if I'm right or wrong, but this group of people is really getting knowledgeable and thinking and applying some advanced concepts of hematology. Fantastic. Very gratifying.
Sir, we are actually feeling sad this course getting over soon.
No, we will stay in touch. But what I'm thinking is after this course is done, then we will have a talk on. I'm thinking of dengue and platelets, right? We've spoken about it, but I think a lot of our colleagues. So, of course, the WhatsApp group will be active, and you have all of you have my number, so you can reach out to me. But this is not where everything ends. As we will keep on giving you updates of newer, diagnostic tests, treatment tests, transplant. Uh, um, uh, After a few months, I'm starting two new courses. One is for oncologists and hematologists to teach them about stem cell transplant. The second one is with the WHO for the pathologists for diagnosis of hematologic cancers. And this course that we are so fortunate to have AFPI work with us. API and IAP are also keen on having this course. So I think I love academics and I think we'll continue to interact.
Sir, one more thing I just
Hmm.
wanted.
Please, Rajat. Yeah.
Sir, recently we had a patient, and the patient was for surgical fitness for some mild endochondroma removal from her great thumb, from her thumb base, and her platelet count accidentally found to be came out to be 41,000. She did not had any bleeding manifestation. So just wanted to ask, like, how should we approach to thrombocytopenia in case of giving surgical fitness? Should we plan for SDP or not? Or
Okay.
we give her
Good
clearance
question.
as platelet counts were 41,000, or we should wait for 50,000. All other viral markers were negative. She was negative, and her peripheral blood film was normal.
Superb. So, I like the way you have been thinking about this patient. Now, you see, we go back to approach to thrombocytopenia. So, you looked at the peripheral smear, you saw that there are no platelet clumps, you saw that
Yes,
she
sir.
does not have giant platelets. You ruled out pseudothrombocytopenia. Then,
Yes,
once you know it is genuine thrombocytopenia, you did a dengue test, correct?
yes, sir.
And
Yes, sir.
that was negative. Then you have to
Yes, sir.
see whether there is TTP or HIT. So heparin-induced thrombocytopenia. So there are no schistocytes. Heparin has not been given. Now this is a patient
Yes,
who
sir.
genuinely has thrombocytopenia. As we have discussed
Yes, sir.
before, any cytopenia, our approach is, whether the raw materials are there or not. So you'll do B12,
Yes, sir.
folate, etc. But generally, isolated thrombocytopenia is not B12 deficiency, because B12 deficiency will
Yes.
first have anemia.
Also,
But
anemia.
nevertheless, raw materials are okay. The factory is okay. So you will do a bone marrow test in this patient. There may be evolving MDS or aplastic or even a leukemia for that matter. Many times, leukemia is incidentally diagnosed because of something else is going on. And finally, increased consumption. So raw material factory, increased consumption. So if raw materials are fine, your bone marrow is fine, liver spleen is fine, ITP, right? Now, that's how you come to the diagnosis. In terms of clearing for surgery, and I don't think we've taken a class on this, but we can do that if it's not there. Dr. Soumya, please
No,
advise after.
no, it is scheduled next class, sir,
Awesome. So
actually.
next week I'll be
Okay, sir.
talking about preoperative clearance in hematology, but I'll still give you an overview, right? So in an urgent surgery, somebody comes with trauma or ruptured ectopic appendicitis, give platelets, clear for surgery. Simple. Emergency, right? Along with
Okay,
platelets,
sir.
PTAPTT, ensure that PTAPTT, if required, FFP, cryo, whatever is required, you are giving everything to perform a good clot. When the patient goes for surgery, go in the OT and do the marrow at the same time. Okay, don't give steroids. So give products, blood products, clear for surgery, just pre-op, finish off the marrow. Tell your hematopathologist, hey boss, I need the report, patient has gone for surgery. Now, if it's not an urgent surgery, if it's an elective surgery, so cataract, dental extraction, hernia repair, you have 3-4 days. In that point, you evaluate, do marrow, etc., get a diagnosis, and then treat accordingly. Sometimes what happens is this turns out to be aplastic anemia or MDS, which you cannot cure. There is no rapid cure for it, right? It's going to take a few days or months of treatment, immunotherapy, maybe bone marrow transplant. So at that point, just give platelets and clear for surgery. That's it. But next week we'll discuss in greater detail.
Okay, sir. Thank you, sir.
You're welcome. Also, one request to you, I'm not able to keep up with my WhatsApp messages. So if you want to discuss any patient, you send the patient's reports to me on WhatsApp, but call me and tell me, can you please look at this? I want to discuss this patient. If you just send the WhatsApp, I may not notice it, So want to discuss a patient, just feel free to call. If I'm busy, I'll disconnect and I'll call you back, but it's better to straight call. Yeah. Okay. Wonderful, everybody. Such a nice chat. So good to connect with you again. Dr. Soumya, you want to say something?
No, sir, I was just thankful for all the classes that, as you can also see, many family medicine specialists are empowered now in
Yeah,
dealing with hematology cases better. Our approach and confidence levels definitely have improved
yeah,
and helping patient care management. So if
yeah.
you are free, next class can we hold on pre-operative fitness? What are the
Yes.
angles at which we look? And
Yeah, yeah. So next will be 1st May.
uh,
Um, I'm free. I'm okay. I can have the class one next week, next Thursday.
first May. If
Yeah,
all of you are okay, because many of you have holiday on May
yeah,
1st.
yeah. And maybe a long weekend, people may be going out. I'm free. If you guys are okay, we will have it. Or we'll push it by a week. I leave it to you guys. If you want, we can finish it on next Wednesday also. So if you are going to go out with your family on Thursday, 1st May, we can do the class on 30th April, which is a
Yeah,
Wednesday.
that would be great, sir.
Yeah,
30th. Yes, sir.
yeah. We'll request you, Dr. Somay, to just give me a reminder on
Yes,
Tuesday.
yes. I'll do it on Tuesday itself or earlier, Monday itself.
Yeah. Thank you so much. Bye, guys. See you next week. Bye.
Thank you, sir. Good day.
Thank you very much, sir.